Hi everybody, welcome again to Dr. Manny's YouTube Learnshops, and this is part 2 to a session that we did previously on social sciences and how it relates to nursing. At the end of this session we'll probably be able to discuss social sciences in a nursing context, which you've done before, and we should be able to discuss the relevance of social sciences in nursing, which you've also done before in certain other courses like behavioural sciences and social sciences. So consider again, on reflection, what is social science? Is nursing a social science? Are nurses social scientists? Social sciences, are they relevant to nursing? If they are, why are they important to nursing? If they're not, why aren't they important to nursing? And does social science actually facilitate nursing? Consider those aspects as we go through. What is social science? Is nursing a social science? Are nursing social scientists? Is it relative to nursing? If it is, or it isn't, does social science facilitate nursing? Right. Do you think nurses need to learn social sciences? And if you do, why? Think about this. A lot of this is going to be reflection, which we can discuss on WhatsApp or through other portals if you choose to. How does nursing relate to social science? Well, incorporating social sciences into the study of nursing from the academic point of view emphasises the social nature of healthcare. It helps nurses to understand their role as social agents. You have a role in society, and it's your job that requires interaction and understanding with many different types of people. As you've already experienced here in Malaysia, this is your country. It's multicultural. It's multidimensional. Because you have lots of different people from a variety of different backgrounds. Malay, Chinese, Indian, all the different tribal sections, Iban, Badayu, etc. Do social sciences actually help nurses? Well, it does. I mean, it does. From my perspective, it facilitates nurses, first of all, their understanding of themselves. You've got to understand yourself first before you can understand other people. Okay? It helps you understand other people, their cultures, and their environment. And in that way, you'll be able to help them as a healthcare provider. It's important as well for understanding social conditions and phenomena such as physical abuse, domestic violence, crime, poverty, child abuse, things related to human nature, which we've discussed in the past. Just look at the world currently. And finding solutions to such problems in a society. So you may be a social agent that actually helps change a phenomena or an occurrence or an event or an action or something in society in the future. We've reviewed this before. Let's just review it again. So what then is social science? Social science is considered a field of human knowledge that deals with all aspects of individuals and group life of human beings. Subjects that examine and explain human behaviour. That's what social science is all about. Human behaviour, we've discussed in the past, in behavioural sciences, is the function of a person's characteristics and the characteristics of the surrounding environment. Look at the cartoon, father to son. I'm a social scientist, Michael. That means I can't explain things like electricity, anything technical, but if you ever want to know about people, I'm your man. I can help you. Nurses, in my opinion, are social scientists because we help people. We care about people, I hope. What are social scientists? Well, it's an academic discipline concerned with society and the relationships among individuals within that society. And as we've stated in the past, and as we've discussed in the past, there are certain empirical or practical approaches: anthropology, economics, political science, geography, psychology, and sociology. Why? Why study social sciences? Well, it's to acquire more knowledge about what it means to be a human being. It helps us as people, as humans, as nurses, understand the mystery of society and improve our interactions with each other, ourselves, our families, our patients. When we understand ourselves better, we understand our world better, and we integrate more effectively. Once we understand, we're able to identify problems and create more effective solutions. Your role will be to identify healthcare issues in practice, and in such you will come up with solutions which I hope you'll investigate through evidence-based practice and provide evidence-based rationale and solution changes. What are the three major theories? We've discussed these in the past as well. So let's just review briefly. The first theory, major theory, is functionalism. Remember Emile Durkheim. And his views were that society is a system of highly interrelated structures that function collectively in harmony. They all work together. One helps the other. Then you've got conflict theory. Karl Marx, he's the father of conflict theory. And he essentially viewed society as one huge class struggle with a lot of inequities. Then you've got symbolic interactionism, Herbert Blumer. And this was a theory that examined the relationship of individuals within their society by studying how they communicated and the symbols that they used to communicate or interact, interactionism. Social sciences in a nursing context, as we've discussed in the past, is multidimensional. So if you're looking at nursing, you're looking at anthropology, you're looking at humanity. If you're looking at sociology, you're looking at interaction of people. You can be looking at the psychology, which is to do with the behavior of people and related to mental issues. You can be looking at economics, wealth and income. Money's important. Capital's important if you want good healthcare in most societies. Historically, past events are important. Look at the foundations of nursing. Look at the foundations of healthcare, which we discussed in the previous section. Very, very complex, but really incredibly amazing. And the 21st century is going to be even more incredible. Look at the geography, man and his environment, because this will have an effect on health and illness. Political science, looking at government and politics. They're the power base. The power base determines what we have in health, health care, and treating our illness. And it all interreacts or interrelates with communication, legal aspects, and spiritual concerns. Let's look at another class activity for you to think about. Is nursing a social science or a natural science? Look at the comparisons. Social science versus natural science. Natural science is a branch of science that deals with physical aspects of the world. It includes fields such as biology, chemistry, physics, the earth sciences, and astronomy. And it always uses scientific, quantitative, positivist methods. Students who use this methodology, which again is advocated in most cultures in the world, they advocate mathematics, they advocate learning physiology, chemistry, etc., and so forth. Students who use this science can become medical doctors, nurses, engineers, biologists, chemists, astronomers, etc. If you're looking at from a social science perspective, according to the academics, this is the study of human society and social relationships. It includes fields such as economics, political sciences, law, geography, and history. And it uses scientific methods as well as other methods, which we know as qualitative methods, subjective methods, which are often viewed by other disciplines such as medicine as being unscientific. Students who use social sciences can become teachers, lawyers, linguists, historians, writers, journalists, accountants, etc. But again, from my perspective here, and other academics' perspective here, also nursing. Nursing is unique. Nursing, from my perspective, is unique because it incorporates both the social sciences and the natural sciences. And from my perspective as well, it should apply to medicine as well. Medicine really should be considered a humanistic, caring profession as well. You're dealing with people. People get sick. Think of another activity. Are nurses considered social scientists? Yes and or no. You decide. This is from an academic point of view. Think about this. Nurses have to learn anatomy and physiology, basic medical sciences. You've all had to do that. And you've got to independently assess whether things are effective. The nursing process. And this is within your scope of practice, a patient's condition, and their needs. You've got to understand pharmacology as well. You've got to understand medications because you've got to give your patients medications, observe their effects, observe and report any adverse effects, and you've got to keep up with evidence because we're talking about evidence-based practice. So physicians absolutely have to because they're prescribing these medications, but you've got to make sure that what they're prescribing is appropriate for that patient. I mean, you may have, for example, here a patient who's in heart failure. They're in acute pulmonary edema. They're already put under fluid restriction, and the doctor has prescribed a diuretic to offload fluid, decrease preload. They're polyuric, they pass urine, they continue to pass urine, they continue to pass urine, they continue to pass urine. They don't need to pass that much urine. So therefore, it would be you in your assessment and to give feedback, say, look, doctor, the patient has passed the urine, they're hemodynamically stable. Do you think we should consider reducing or stopping the dose of this diuretic? Nurses generally care for patients 24 hours a day, 7 days a week, more so than other healthcare professionals. They are responsible for assessing a patient's needs when they're admitted and maybe offer referrals. For example, a patient isn't automatically seen by a social worker. Let's say, for example, here, Economically, there's a problem. They've got problems at home. They can't supply or provide for their family as effectively because, again, maybe they're unemployed because of the COVID-19 situation. But when the nurse observes there's a need, he or she can make a referral to the social worker, to the doctor, to a healthcare provider that can help the patient for whatever situation that they're in. So you can offer referrals. You're also responsible for teaching patients because you're knowledgeable. You teach them about medications, their activities of daily living, maybe activities like dressing changes if required, how to administer subcutaneous injections such as insulin, how to care for certain invasive lines that are related to chemotherapy because they're going home. Maybe you work in a dialysis centre, so you could provide dialysis because they're going home and they're having self-administered home care peritoneal dialysis. So realistically, from most academics and from my perspective, and I hope from your perspective, you are a scientist. You're evaluating research, evidence-based practice. You're a social worker because you care about the people that you're interacting with. And you're an educator. Your role is multidimensional. So then, think again. Relevance. Is social science relevant for nurses and the nursing profession? Well, let's reflect. The goal, social science in nursing. The primary goal is the promotion of health and the prevention of illness or any injuries. Nursing and medicine both have common goals of illness prevention and restoration of health. They are health sciences, they are social sciences, and they are natural sciences. Medicine, however, comprises of primarily diagnosis and treatment. It should incorporate caring as well. Nursing is a care process. We're considered a caring profession, whatever that means. The definitions are not all generic. So what's the relevance? Sociological knowledge, or knowledge dealing with social sciences, allows nurses to enhance the quality of their patient care in a variety of settings, which could be neonatal, pediatric, adult. It can be gerontology. It can be oncology. It can be intensive care, coronary care, critical care, long care. These are acute and chronic healthcare facilities or settings, and even home care. You may be interested in providing community nursing, which has an element of home settings, or you may be employed privately to care for someone in a home care setting. So therefore, it's important to understand individual patients' social context because it provides insight into how they experience the world. And in particular, their experience of illness, health, disease, and the associated care. What's the relevance? Well, again, you're thinking about this. This knowledge allows nurses to recognise ethnocentric behaviours, conflicts that obstruct effective patient care. For example, if you're prejudiced now to people eating with their hands and fingers, which Malaysians are not, but I can guarantee you in the West, they would look at you very strangely. Unhygienic. Well, it's not if you've done the appropriate hand hygiene prior to commencing your meal. To recognise and accept individual differences. For example, body structure. People are very, very critical of the overweight, and even the underweight. There's something wrong with you. Well, there isn't really. We're all individuals. Being morbidly obese, sure, that's unhealthy, and that requires addressing. It allows you to respect other cultures. For example, here, when I first came to Malaysia, or even when I was working in Saudi Arabia and teaching and educating Malaysian nurses who were already post-registration, I would often, for example, point my finger and wasn't aware that this was considered to be rude, viewed as being aggressive by certain different cultures, whether Indian, whether Malay, even Chinese. So I learnt to open my hand, palm facing upwards, instead of pointing with a finger. It was less threatening. What's the relevance of social sciences in nursing? Again, this includes a broad range of issues which we've discussed in previous lectures and reviewed in previous courses, but issues related to social epidemiology, healthcare organisations, patient and patient care practitioner interactions. We looked at health and illness behaviour. We looked at patients' expectations and responses, even when you considered yourself what it would probably be like to be a patient, or if you had a family member who was a patient. And we've looked at chronic disease progression and chronic diseases. So then think as we evolve. Is social science important for nurses? Social science and its importance for nursing. Social science is included in most nursing curriculums globally. No, in all nursing curriculums globally. Yours, behavioural sciences. Yours, social sciences. Yours, social sciences and health. Health is a social factor. And most illnesses have social causes. So, for example, if there's a problem related to geography, you can't get access to healthcare clinics because you live in the middle of nowhere, deep in the jungle, in your kampong. You may not get access now to knowledge and education about smoking, about tuak drinking, about the consequences related to your heart, your brain, your liver. You don't know. There are other social causes related to economics, which we've discussed. I mean, if you are in a low-paying occupation, then you may not have money available to provide you with nutritious food. So you may advocate for Panda, Grab, fast food, KFC, McD, Herfies, Cubsa, etc. Noodles, roadside, etc., etc. So therefore, social causes such as those that we've discussed previously can have social consequences, which we've also discussed. The social consequences are that if you do have a heart attack or a stroke or develop peripheral vascular disease and go into renal failure, then you'll become a burden to yourself, your family, and to the community. It has to be included in nursing because it provides knowledge for you to understand the community and patients, their habits, their norms, their culture, their behaviours. And in the process, you will learn about yourself and about your family. Maybe this will influence you to convince your father or your mother to stop smoking or to start exercising or to start thinking positively or to start growing healthy vegetables, which can be done in any garden. It also can provide information for you about the value of change, which we just said. Changing your practices, changing your activities of daily living, changing the environment from an unhygienic one to a hygienic one. Practicing things such as what we're going through right now. I mean, it's astounding to me that we are all, because of the COVID-19 situation, being told to practice universal precautions. Well, we should have been practicing them before, but think, reflect, we weren't. Hand hygiene. Children in school, as far as the evidence goes, go to the internet, have a look. They're not practicing hand hygiene when they come out of the toilet. They go directly now to eat. So it would be a concern to me then that person who's now cooking those noodles for me, when I see him scratching his nose, and I'm saying that gently, or scratching his butt, or he went to the toilet now, did he perform hand hygiene before he picked up my noodles in his ungloved hands and put them in the pan? I've seen this happen in McD as well. I've seen this happen in Australia. I've seen this happen in Saudi Arabia. We've been told to practice hand hygiene. We should have been doing that anyway. We've been told to use personal protective equipment. It doesn't mean gown, gloves, goggles, hats, shoe covers, etc. Personal protective equipment basically means that here, anything that can now protect you or whoever you're coming in contact with. So if you have a cold, well, why not get a surgical face mask to protect you and, or not protect you, to protect your family when you cough with droplets? Or consider using cough etiquette. Don't cough into your open hand or out into the room. Cover your cough with the back of your hand, your elbow, your shirt, your scarf, a tissue, a handkerchief. And most importantly, dispose of contaminated items correctly. Just go out for a walk, even here at Unimass. Litter, it shocks me when I look at the roadside, the filth. So if you're not disposing of tissues or face masks correctly, this can promote the transmission of disease. Physical isolation is another standard precaution. It doesn't mean physically isolating yourself or social distancing, but basically what it means is don't share personal items. Don't share food. Don't double dip when you're using your hands to collect food to eat. This is potentially able to transmit infections. Physical isolation in a healthcare setting means if you're going from one patient to another patient, make sure doctor, nurse, physiotherapist, that you have cleaned your stethoscope, that you've done hand hygiene, that you've washed or sprayed or disinfected that other piece of equipment, thermometer, blood pressure cuff, etc., before you go to the next patient. And the list goes on. There are 6, sometimes 7 universal precautions which we should be implementing, which we don't. But we should be doing that in daily life and certainly in healthcare practice. In curriculums of nursing, you're told you're a patient advocate. So be a patient advocate. And part of that role is to educate. And we educate nurses to approach the patient on 3 specific levels, which are as follows. An emotional level. So appreciate and understand a person's emotions at the time of a specific moment. Understand. For example, if you're a father or a mother who's just been informed that their 5-year-old son has died from the injury sustained from a motor vehicle accident, well, be caring, be compassionate. And if you are the nurse involved, you have a social worker role. And your role should be one being caring, sensitive, and provide an opportunity for the parents to ventilate their emotional state. It's terrible news. And you do so without judgment. That's the important thing, because the father may have been driving the car, or the mother may have been driving the car, for example, and they didn't have their child sitting in a safety seat, or they didn't have them wearing a seatbelt. And as a consequence, the child was injured because it was thrown out of the car, or went through the windscreen, or hit the back of the seat, or hit the steering wheel, etc. So think of it from an emotional point of view. In my career, I've seen some terrible things done and said by physicians. However, look, not everybody's a social worker, but that's what you should consider. Always put yourself into the patient's or the family's position. Then you're looking at the cultural level. Look, the patient might not be able to adjust to the hospital or the healthcare environment due to certain cultural issues. For example, it could be a married Indian female who may refuse to remove her Mangal Sutra, I hope I've pronounced that correctly, prior to a procedure or surgery. The nurse shouldn't be judgmental. She shouldn't be fierce or scolding. You have to remove it because that's the order. You have to remove it because that's what we always do. The nurse should be culturally sensitive and explain gently the rationale for why it's important to remove the jewellery prior to any operation. And look, it may be a procedure or an operation where it doesn't require removal. But if, for example, you're having a chest x-ray, or you're having an x-ray of the head and neck, or you're having surgery in relation to that area, then it's important for it to be removed, and it needs to be explained in a simple, clear manner to whoever the person is. And to the family, because the husband may be there and it needs to be explained. If the husband gives approval, then it should be okay. It has to also be on an intellectual level. The patient may be unable to understand. You've been exposed to this, just with people in your own community, in your social circles. The patient may be unable to understand or appreciate the instructions or guidelines provided by the doctor. Common. The doctor uses medical jargon terminology and the patient's got no idea what is going on. They are not educated. They're in Kampong so-and-so. A lot of them might even be illiterate to their own language. They can understand it, but they can't read or write. A lot of them may not even be able to understand Malay. So, for example, you've got an illiterate Iban man with heart problems who's prescribed medications because he's hypertensive and we want to prevent stroke. However, he insists that his traditional medicines are sufficient. They're enough. So rather than being judgmental or uncaring, the nurse, as a social scientist, as a natural scientist, as a combination of both, should be calm, sensitive, culturally sensitive, and explain gently the importance for the medication. And this would probably be beneficial to be explained in the presence of the village leader, maybe, or in the presence of the family, so that they get support. and comply. How else is social science important for nursing and the nursing profession? Well, as we've discussed previously many times, it facilitates understanding of a human being's behaviour when they're healthy and when they're not healthy, they're ill, or they have an acute condition or a chronic condition or a terminal condition. It provides culturally sensitive patient care. You, as a healthcare provider, have to be culturally confident and sensitive. It allows you to recognise a patient's psychological, physical, and social problems. Holistic nursing. And it allows you to interact on a multidisciplinary level with the healthcare team, which provides collaboration. Holistic care in hospitals and in the community is being advocated because we're not looking at the patient as a disease or a number, we're looking at them as a whole. That's nursing. You're providing resources for patients, their families, in the continuity of care. When you have an illness, it may be continuous. I mean, if you're diagnosed as having diabetes mellitus, well, there's a continuum of care there. The disease can be controlled, but can't be cured. And it's important to promote positive attitudes and to be positively motivated. What else does social sciences do that is important for nurses? Well, it informs. It's important to differentiate between health myth and reality, which we've discussed. It provides information about the benefits for both rural and urban populations, which is different. Because in the rural community, as we know, information may not be filtered to the rural community, whereas in the urban populations, that's where most of the clinics are. That's where most of the hospitals are. That's where most of the doctors are. It's important to be culturally sensitive to people's values and norms, and not to be judgmental, and not to criticise. Because interestingly enough, some of the traditional medicines, whether they be tribal, Malay, Chinese, Indian, have benefits, whether they're physical or psychological or both. And it's important to regard cause and effect relationships to disease. And it informs about distribution and social determinants of disease in the different populations and locations, which we've discussed. We've discussed this, how you have illnesses that seem to be racially prevalent, which typically occurs in certain populations like, as we discussed, in the United States of America, African Americans, but this can be related to darker skinned populations as well. There are diseases, as we've discussed, that have a preference for the Asian community. And there are some, again, that relate to white or Caucasian populations, such as skin cancer. So let's remember briefly, what are health behaviours, which we discussed in behavioural sciences and social sciences. Health behaviours are how we behave towards health. These are a person's beliefs and actions regarding their health, their well-being, and their response to illness. They're absolute factors which maintain a healthy lifestyle or an unhealthy lifestyle. And they're influenced by social, cultural, and physical environments in which we live and which we work. And they're shaped by individual choices, and they promote health and prevent disease if they are positive. and they're influenced by social and cultural norms. I mean, if you're a kid and you see your dad smoking all his life, it will typically result in you wanting to smoke because you want to emulate your dad. Or, by the same token, or in an opposite perspective, you see your dad smoking, and as you get older, you notice that he has breathing difficulties. He's got cardiovascular problems like hypertension. He's constantly coughing. He's constantly going to see the doctor. He's constantly unwell. He can't work. Then you may decide, well, this is not a health behavior that I will want to emulate or follow. And hopefully your dad would support you in that decision, because he doesn't want you to do what is happening to him. So think then, you, and this can be personal, this can be professional. Does the nurse have a role to change a person's healthcare behaviour? We asked this question previously in behavioural sciences and in social sciences. Do you have a role? I mean, if you see your mum constantly sitting around watching TV, watching the Chinese or Malay soap operas, not getting exercise, constantly munching on high calorie, high cholesterol products, getting fatter, obese, noticing that when she walks, she becomes short of breath very easily, is it your role to say something to her? To change her healthcare behaviour? I hope your answer is yes. Because as the cartoon image basically says to you here now, it says, well, gee, you can't cure stupidity. If you know your healthcare behaviour is bad and you continue to do it, well, you can't say, well, gee, I'm human. What can I do? You as the nurse have a role to change that behaviour. So think, is it the nurse's role to identify the patient's health, illness, impairing, bad, harmful behaviours? I hope you said yes. Is it the nurse's role to explain positive healthcare behaviours which are protective to the patient? I hope you said yes. Is communication important in the patient-nurse relationship? I hope you said yes, because communication is one of the most important tools. A lot of people, nurses included, they leave notes around everywhere. They leave information in the form of a sign: don't smoke, don't enter here. This is only for males, this is only for females. People do not read these types of communications. Sending a memo. People often, according to the literature, don't read them. It's better to communicate verbally. It's better to communicate the information verbally. It has a greater impact. Sending emails, texts, typically not. Let's look at the nurse-patient relationship. Well, the nurse-patient relationship is defined as a helping relationship that's based on mutual trust, we've said this before, and respect. Nurturing of faith and hope, being positive, being sensitive to self and others. You care. You demonstrate caring. You've got a nice smile. You've got a happy face, not laughing. You've got a calming face. You assist with the gratification of your patient's physical, emotional, and spiritual needs through knowledge and skill. Well, that's very technical terminology, but basically what it means is you help and you appreciate your patient's physical condition, emotional condition, cultural condition, and their spiritual needs. And you can't know that unless you have knowledge and skill, which you learn. And there are essentially 5 key components that relate to this relationship. Professional intimacy, which means, geez, be ethical. I mean, don't go telling everybody when you go out, gee, I saw the patient with this and they had that and here, and the patient's name and number was such and such. Okay, and I mean, the thing is here, look, I mean, he's got COVID-19, he's positive here, and his age is this, and this is where he lives, etc. And so people were doing that. Don't share this information on WhatsApp. I'm astounded that here information about patients are shared between doctors and nurses on WhatsApp. WhatsApp is not a secure website, so therefore anyone can potentially get access to it. It relates to power, empathy, respect, and trust. So regardless of the concept, the length of interaction and whether the nurse is the primary or secondary healthcare provider, these components are always present. Trust, respecting the patient, being empathetic, trying to understand, and caring. Remembering that you have got the power. You've got power. It's not an equal relationship. You're in control. You are the one that says to the patient, this is what you should do. But it's not what you say, it's how you say it that will get an effect. Hopefully that is positive. So the 5 key components are professional intimacy, trust, respect, empathy, and power. And they interrelate. They all interrelate. Let's look at them individually, briefly. Professional intimacy. This is the inherent care and the services that nurses provide. It includes such things as physical activities. You're bathing them. You're creating closeness. This is psychological, spiritual, and it's got social elements in their plan of care. And so you have access to personal information, which also creates closeness, but it isn't shared to anyone else other than people that are appropriate and should know. The doctor, your immediate supervisor, the family, not your family, not your colleagues. This is to do with ethics, a moral duty of care. You're looking at power. As I indicated, the nurse-patient relationship is one of unequal power. And you may not realize it, but in healthcare setting, you have more power. You have more control. You are the one that dictates what should happen. In a nice way, I hope. You've got more authority and influence because, again, number one, you're more knowledgeable than the patient. Well, in today's day, everyone has access to the internet, including the patients. You have access to privileged information, and you are a patient advocate. for not just the patient, but also to the family. Don't misuse your power. As I said, you see something interesting in a patient history, you take a snapshot of it, you share it on your WhatsApp website. Or, God willing, know that you share it on your social website. It's important to be empathetic. So empathy refers to the understanding of the healthcare experience from the patient's perspective. We've discussed this previously as well. Be the patient. When you think of yourself as the patient and what they're experiencing, you can validate the experience, because a true patient advocate puts themselves into the patient's shoes and thinks about what they would like, what they would want if they were in the same situation. I mean, they would want someone who is caring in the form of someone who is smiling, not laughing, someone who is tender and not fierce or scolding, someone would appreciate the fact here now that their illness or their disease is having an effect on them, but also their family and their immediate community. They may be young, they may be very old. So it's important to be empathetic. But however, it's also important to remember your professional role and maintain objectivity. There's no point breaking down and crying and sobbing. That's not your role. However, having said that, if, for example, you're in a situation where you are giving emotional support to a family member because their mother or their father or their son or their daughter had just died, and use that terminology. I mean, passed away, not here with us anymore, crossed over to the other side. It's recommended use correct terminology so there are no mixed methods. So that there are no mixed messages. If you're giving information, be accurate, but be gentle. Care. Respect is important, as we know. Respect is considered to be the recognition of the inborn dignity, value, and individuality of every person. Every person's unique. Yeah, sure, we're all human beings. However, we're all different. I'm certainly different to all of you because of the way I was raised in my society, in my culture, certainly different to Malaysians, regardless of the race. And respect is regardless of socio-economic status, money, position, personal attributes, thin, fat, overweight, cute, ugly, and health problems or health issues. Having had a stroke, having had cardiac conditions, being unable to work as a result of that health problem. Trust. Trust is central to every component that relates to the patient-nurse relationship. Because trust is important from a patient perspective and from you as an advocate. Because all patients are vulnerable. Trust, however, is considered to be fragile. Certainly at the beginning of a relationship. Because if I don't know you, I I certainly am not going to trust you. Certainly not things in relation to my emotional health. So it's important that right from the beginning that you're honest. It's really important. So for example, look at the picture here, the little girl. Is this going to hurt? No, it's not going to hurt. Wrong answer. Yes, it's going to hurt a little bit, but it won't hurt for very long. But it will hurt a little bit. So you get ready. I'll tell you to prepare. Absolutely. You look at it if you want to. If you don't want to look at it, you don't have to. Trust is important. Be honest. Be truthful. Keep promises. I'll be back shortly, okay, just to check that you're okay. You never come back. Did that hurt? Yes, it did hurt a little bit. Okay. Mummy will stay here with you, or my friend will stay here with you, another nurse, but I will come back to make sure that everything is okay before you go home, or before I go home. Because once trust is lost, it's difficult to re-establish it in every situation. If you can't be reliable when someone is in a potentially distressful situation, that's going to be a problem. I referred to this trust in an article that I wrote in 2020, which was referred to as vulnerability, which means vulnerability related to patient advocacy. Because all patients are vulnerable and potentially vulnerable. So how are you going to prepare for professional practice? You are a professional. Nursing is a profession, which means you're accountable for your actions. How are you going to prepare? Okay, let's review some of the professional practice ideals which are recommended. When you commence professional practice, for example, your first year as a nurse, student, or as a registered nurse, is probably going to be the most challenging in the literature. However, people like punctuality, especially me, especially if you're a professional. Always be on time. Unless you've got a valid reason, if you have a valid reason, try and inform the person, the head nurse, the matron, the lecturer, your mother, in advance. Don't complain. Leave your personal issues at home. Leave work-related issues at the hospital. Find a mentor. A mentor, as we've indicated, is someone that you have a lifelong relationship with. It's not a preceptor. A preceptor is short-term. A mentor is potentially forever. Learn to be assertive, not aggressive. Learn to be assertive, but don't pretend that you know something when you don't. You'll soon be found out, and you'll lose credibility, and you'll lose respect. It's important to be flexible and open to suggestions, but never be afraid to ask questions. And always clarify if you've got any doubts. So that means if a doctor has given you an order, or your preceptor has given you an instruction, or the patient has asked you about something and you're not sure, clarify. Get them to repeat it clearly or more simply, because again, you can be saying here now, look, I don't really understand what you're saying. Would you be able to explain it in another way? And if you can't, get someone who can. Learn to admit your mistakes. Look, no one's perfect. We all make mistakes. And when you do make a mistake, don't dwell on it. I mean, it's not the end of the world. You're learning. Mistakes are important because this is called experience. You learn from your mistakes. Hopefully, you don't keep making the same mistake over and over again, because according to Einstein, that's stupidity. Making the same mistakes over and over again doesn't make sense. You're not learning. So when a senior nurse or a colleague or even a patient questions you about your care, did you wash your hands before you gave me that medication? I didn't see you. Don't take it personally. If you are giving medications, develop a habit. Learn about the medication that you're giving. You should not be giving any medications that you don't know the rationale for, the actions, and the potential adverse effects. And most importantly, don't forget about known allergy status and your medication rights. Double check everything. Always ask an experienced registered nurse or maybe your preceptor or colleague to check all high alert medications. Because high alert medications are any medications that could potentially put the patient at risk if given incorrectly. Always check the patient's vital signs before giving a cardiac medication, because cardiac medications typically cause a slowed heart rate. And if they've already got a bradycardia and the doctor's order was if their heart rate is less than 65 or 70, withhold the medication and report. Look at patient issues. Look at the patient holistically. We've discussed this. Not just as a disease. Look at the patient's emotional state in comparison to their physical state. Educate the patient and the family. Pediatric patients, always consider what parents say. I could give you numerous examples. The parents said, look, my son had an allergic reaction to this medication last time it was given. And you say, oh yeah, but the doctor ordered it, so it has to be given. The medication is given, the child has an anaphylactic reaction, and a code blue is called. Problem. Patients, family, children's parents know the patient. So listen to what they have to say, and then possibly consult with the physician or your preceptor or your immediate supervisor. Asking questions. Always be specific and direct to the point. Don't dilly-dally. Don't waffle. Don't pad. Be direct. It doesn't mean that you're being aggressive or fierce or scolding, I hope. Even when you're tired or you're stressed or you have some situation, always approach the patients with positivity and a smile. Body language is the first thing that is observed by any person. The first thing a person looks at is your face. And if your face demonstrates being fierce or scolding or negative, they may not want to approach you. They may not want you to care for them. Never leave a patient saying that you'll be back in a minute and you never come back. Never lie to your patient. Tell them the truth. However, truth within your scope of authority and within your scope of practice. So, for example, if the patient has now been diagnosed with a terminal condition which they're not aware of, and it's documented in the history because the doctor documented it, it's not your role to tell the patient that. It's not your role to tell the family that. It's the doctor's role to tell the patients that. Or if the doctor doesn't want to tell the patient that and he wants to allocate it to the social worker or the psychologist, depending on the situation, then that will be documented as such. But don't lie to the patient. As I said, oh, this is not going to hurt you, and it hurts them a lot. I will come back. I'll come back to see whether that medication has worked. I'll come back to see whether there's any transfusion reaction, blah, 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 etc. But you don't come back. That's a problem. It's a trust issue. It's an ethical issue. It's a patient advocacy issue. Medical staff. If you're dealing with medical staff, know your facts. Before calling a doctor, regardless of the time, always make a list of things that you need to mention so that you're not calling back every 5 seconds and disturbing the doctor. Because the doctor has got 100 patients, you may only have 5 or 6 or 10 patients, or more, depending on the hospital that you're with. But the doctor is responsible for the whole ward, other wards, and possibly even the intensive care. A good tool to use, I'm not sure what you use here in Malaysia, but a good tool that's recommended by the Joint Commission International for Patient Safety and the World Health Organization is a tool called SBAR, Situation, Background, Assessment and Recommendations, or the equivalent for effective communication. When you're considering yourself as a professional nurse, student or registered, don't be too hard on yourself and listen to yourself. Listen to your gut feelings, your intrinsic feelings. Nurses are very good at that. Listen to what your inner self is saying. In most cases, either about yourself or about your patient or about your situation. It's in the evidence. It's in the literature. Nurses have a gut feeling. So, for example, you've got a patient now whose vital signs are reasonably normal. However, you feel that there's something not right. Something is bugging you. Something is concerning you. Listen to it. Because the literature says, this is evidence-based, that you're probably going to be right. I had a situation, many situations very, very similar, where I said to the doctor, look, doctor, we need to escalate this patient. We need to admit them to the intensive care because they've got a respiratory problem. It seems to be getting worse. It's okay at the moment. Respirations are fine, but there's been an escalation in their rate from a rate of 15 to now 20, 22. Saturations are okay. Not listened to. 15 minutes later, code blue, ward wherever, patient transferred to intensive care after being intubated and ventilated. So always listen to your inner voice. If you're concerned about something, express it. Uphold your integrity and be a nursing ambassador. You're a role model. People observe you. Nurses in the global community are the most acknowledged and respected profession. Maintain your nursing competency and invest in continuing education. Be evidence-based. I know you're not going to do it, but you should be reading some form of literature that relates to nursing every day. especially in relation to where you're practicing. So, for example, if you're a student and you're working in intensive care, go to the internet and look at something related to a patient that you might be caring for. So, for example, here you may have a patient on mechanical ventilation. Look at mechanical ventilation, get an article. What's the rationale for it? What are some of the complications, etc.? Understand the concept of evidence-based practice. That is what it is. Know your scope of practice. You're not a doctor. You're not a social worker. You're a nurse. Understand your role and the limitations of that role within the scope of practice in relation to what you're allowed to do, what you're authorised to do according to the university if you're a student, or the organisational policy if you're a registered nurse. My advice is also learn how to do a physical assessment properly, because it serves as a foundation for your care. Nurses globally, doctors are worse, cannot do a physical assessment properly. Just look at the way some people listen to a person's chest. In a chest, you've got a number of different sounds: heart sounds, breath sounds, and vascular sounds. Always perform hand hygiene with the World Health Organization's 5 moments of hand hygiene, and understand how it is effective. Identify where the emergency drugs and the equipment are kept. It may not be your responsibility to respond to the code, but if there's no one else there, know where it is, so at least you can bring it to the area when the resuscitation team or the Code Blue team arrive. At all times, especially in front of your patients, appear calm and relaxed, even though you feel like you're going to collapse. This reflects on you and the organisation, and the patient doesn't want to feel that you're going to be distressed and not be able to do what you're supposed to do. I mean, for example, if someone's experiencing severe chest pain as a patient and you suddenly have a freak out event, it doesn't inspire confidence. You have to be calm, collected. Everything's okay, madam. I will call the Code Blue team. I will activate the emergency medical response. I will call the doctor. I will get you help. But I will stay here with you the whole time to make sure that you are okay. It's okay. Stay calm. Try and relax. I'm here to support you. Stay away from negative people. We learn about this when we look at positive and negative attitudes in behavioural sciences. Okay? Stay away from negative people. You don't want negative people. You want positive people. And patients certainly don't want negative nurses. No one, remember, no one can make you feel incompetent unless you allow them to. No one can make you feel bad about yourself unless you let them. If someone's being negative to you, be positive. Thank you, sir, for your feedback. It's not correct, but I appreciate your comments and I'll consider them, and I'll discuss these issues with my head nurse, with the doctor, with your family, etc. No one can make you feel bad about yourself unless you allow them to. Remember that. Not growing professionally. If you don't feel that your chosen field, for example, you've been allocated to the ophthalmology unit and you feel, well, gee, this is boring. Look, as a student, it's part of your role to understand that. It may be not where you want to professionally evolve to, however, don't be negative. This will be demonstrated to your patients. It'll definitely be allocated to and picked up by your clinical instructors and your preceptors, and it will have negative outcomes for you. However, if you are not growing professionally in the area that you chose, for example, you decided to go into intensive care, and you decided now, well, gee, I'm really stressed Every day I come in here, I can't concentrate. This is really not what I want. Choose another option. Go into a less acute area, maybe HDU. Maybe going into a less acute area, maybe surgical medical nursing. Maybe go into another area, maybe gerontology. Maybe go and work in a clinic. Maybe go and work in the community. Maybe go and work in home care. You decide. Because if you're in the wrong area, you're not going to be positive and you're not going to benefit your patients. Remember that. When you feel like giving up, everybody sometimes does. But remember the reason that you became a nurse. Look, on reflection for me, I became a nurse because at that time it was an occupation where I could get paid, I had responsibilities, and I could learn at exactly the same time. So therefore, the original reason I guess I became a nurse was because I needed money and I could get a career where they would pay me to learn. You don't have that option these days here now, unless of course you go and do other post-registration courses such as coronary care or intensive care, and the organisation supports you in that sense. But the primary reason we all became nurses, and mine as well, really, on reflection, was to care about people. Because you care about people, because it's a caring profession. I thought this was interesting. This is called the Nightingale or the Florence Nightingale effect. The Florence Nightingale effect is a trope, which is a figure of speech, where a caregiver falls in love with their patient. And even if very little communication or contact takes place outside of the basic care, the feelings eventually may fade once the patient is no longer in need of care. And from my perspective here, it's never really happened to me other than with my paediatric patients. And I really have. I've fallen in love with the little guys, especially in oncology. Little James, 5 years old, an acute form of leukemia, and I adored this little boy. Went off one weekend, came back, he died. It broke my heart. But eventually you get over it. I never forgot him though. Little Simon, blonde, blue-eyed, 4-year-old boy, hit by a car while riding his bike, didn't look before he started crossing the street, admitted to my intensive care. Not a mark on him. Not a mark on him. Severe head injury, diagnosed as brain death. Intubated, ventilated, a lot of hemodynamic support. He looked perfect. But the decision was made to terminate his life support. I'd looked after him now for about 2 weeks, interacted with his family. I felt like his big brother. Broke my heart again when we terminated his life support. And even though he was theoretically already dead, not passed away, not gone to the other side, not left us, use the correct terminology, he was clinically dead because he was brain dead. This effect, however, is named for Florence Nightingale, who, as we discussed previously, was a pioneer in the field of nursing in the second half of the 19th century, and due to her dedication to patient care, she was dubbed, as I also indicated, the Lady with the Lamp, because of her habit of making rounds at night, previously not done. Her care would, however, change the way hospitals treated patients. Because before, the ill, the infirmed, those who required care were not treated very well. Most consider Nightingale the founder of modern nursing, as I've indicated previously. However, there's no record of Florence Nightingale ever having fallen in love with one of her patients. In fact, she had multiple suitors who wanted to marry her, but she never married for the fear that it might interfere with her nursing career, or what she called her calling for nursing, which basically meant she was married to nursing. It was more than a career. It was more than an occupation. It was her life. The Florence Nightingale effect. Now let's consider something that you all know, and it's certainly relevant here in Malaysia and in most of the global nations, except for Saudi Arabia. Saudi Arabia is one exception. Very young population. In the 21st century, the healthcare reality is there's an aging society. As we've discussed, there's unequal access because of race, ethnicity, geography, and socio-economic status. There aren't enough nurses, and there are certainly not enough doctors, as is demonstrated globally with the COVID-19 pandemic, as you saw. There are new emerging roles for nurses, which means you're going to have to be technically and educated at a higher level. We're approaching the Industrial Revolution 4, the fourth one, and there are major changes that are occurring in which nurses' roles are going to have to change, depending on the specialty that you're in. There are gaps in the healthcare quality. There are numerous incompetencies, such as medical errors, which are ongoing. Healthcare technologies are becoming more expensive. Some of these modern technologies and drugs are very, very expensive. I mean, for example, when we look at fibrinolytic therapy, for example, fibrinolytic therapy here are medications like tissue plasminogen activator, which is a medication that is given to a person, for example, who's having a stroke, and an ischemic stroke with a thrombus. And this medication dissolves the clot. Or it can also be given for patients who are having a heart attack, so a thrombus, coronary artery disease. This medication, just one application, will cost approximately, let me convert it, probably around about 8,000 to 10,000 Malaysian ringgit for one dose. Not everybody can afford that, but I think the government will support that at some point in time. There are rising healthcare costs. There is affordability in healthcare disparities. Not everybody can afford it. Most people have to go to a government hospital here in Malaysia. Other peoples that are, let's say, rich, wealthy, affluent, have the appropriate healthcare insurance, can go to a private hospital and not have to wait. People are on waiting lists in the whole world, not just here in Malaysia. For example, for therapies such as hemodialysis because they're in renal failure, or cardiac surgical interventions, or oncology interventions, and they end up waiting and dying while they're waiting because they have to wait. They're on a list. There are growing ranks of the uninsured in most countries in the world, even the United States of America. Very, very bad, very scary. And there's an inability to pay. And if you can't pay for something, you won't get the care. You won't get the treatment. Let's look at the patterns of disease and death in the 21st century. We're talking about 2001 up to 2100. There has been a decrease in child and infant mortality overall, but there are still a lot of countries that have a high infant and child mortality rate. Sudan, Africa. Industrialised or Western countries, typically not. There's an increase in life expectancy. The population of the elderly is increasing. There are more communicable diseases. Look at COVID-19. There are diseases of what are referred to as diseases of the affluent, which means of the rich people, or people that have a very nice lifestyle, such as cardiovascular disease, heart attack, renal disease, stroke. Even though, as I mentioned previously, things have improved dramatically, but they seem to be reoccurring as well. There are more accidents, motor vehicle accidents that are occurring because people are human. Current issues that relate to Malaysia and in a Malaysian healthcare context are what they refer to as incompetence of gatekeepers, which basically means doctors and nurses and healthcare providers may not be as competent as we hope them to be, whether it's in relation to the education that they're getting or whether it's in relation to a theory, practice, ethics gap, which is in the literature. Have a look at the theory, practice, ethics gap, which basically means you as nurses are getting theoretical knowledge, and doctors and pharmacists and other healthcare providers. And you have to do competencies, all of you. You all have to do competencies in order to make sure that you are practically safe. However, when you get to the clinical area, you don't do what you're supposed to do for whatever the reason, meaning that you don't do hand hygiene. You don't dispose of equipment correctly, and that way you end up getting needle stick injuries. You don't identify the patient correctly, so the patient gets the wrong procedure or the wrong medication. These are ongoing issues globally. There's a breakdown of the primary healthcare system, which means people aren't getting access to primary healthcare. There are overcrowded government clinics and hospitals. You know what I'm talking about. But this is not just in Malaysia, this is globally. I mean, there are people, and I shouldn't laugh, there are people in the States that sit in the emergency and trauma department waiting for care, and they wait so long that some of them are eventually found dead. Sitting there, they've died, and no one's even noticed it until things calm down. Amazing. There's a shortage of government specialists, which I indicated. I mean, that's you as well. You can be specialists as well, as doctors can be. Where are you going? You're going to Singapore. You're going to Saudi Arabia. You're going to private hospitals because you get more money. There are long waiting times in every country in the world. So procedural waiting times are long. There's the two-tier health system. It's either the government or the private healthcare sector. There are rising costs of co-payments. So if you want additional treatments or therapies or instruments or interventions or equipment, then you're going to have to pay for it. The government won't supply everything. They may pay some of it, but they won't pay everything. And there's catastrophic expenditure, which means, it amazes me that here, but it happens everywhere. It's not just in Malaysia. So, for example, you could be diagnosed with some form of cancer. You get the surgery, you get the radiation therapy, you get the oncology chemotherapeutic interventions, and it costs a fortune. And some people even lose their house. They have to mortgage their house to make the payments, and as a consequence of that, they lose their house, which is really, really sad. Catastrophic expenditures. Let's look at incompetence of the gatekeepers. What does that mean? Well, privatisation has created what is called a brain drain from government hospitals. Private hospitals are paying more. They're paying the doctors, the nurses more. Then there's also the issue of junior doc, and this is in the literature. You can go. I've just included that under health facts for 2019 here, but you can look at the literature. This is happening in a lot of countries in the world. But in Malaysia, absolutely. Competency of junior doctors, here, manning health clinics and outpatient departments of district hospitals. There aren't doctors there. This leads to misdiagnoses and delays in diagnosis, which affects the patient. And this contributes to the phenomenon of patients bypassing healthcare clinics and district hospitals, and they go directly to the general hospitals, which can overload them. The hospitals can be overloaded in this situation because people go to the clinics or the district hospitals. I speak from experience. My mother-in-law, she won't go to these clinics now. She's IBAN because, again, what she's received in relation to care from the clinics, even she has identified has been ineffective or potentially unsafe, and she goes directly to Syrian Hospital or now to hospitals in Kuching. Those who can afford to go to it directly, go directly to private hospitals because, again, they're paying for a service. Breakdown of primary health care. Government hospitals still require what is called screening by the outpatient departments before patients can access special clinics, thus keeping to the primary healthcare approach. This takes time. So from my perspective, when I have an issue, I go straight to the private hospital where I can go straight to the consultant that I want to be seen by. I don't have to go to a doctor who may not have the information that I want him to be aware of. Then he has to give me a referral. Then I have to go to, etc. But this is not observed in private hospitals, which I just indicated, where patients can choose the specialist to see for the initial assessment of their symptoms. No delay. Overcrowded government hospitals. You know what I'm talking about. Wards routinely have more than double the number of patients that they were built for. Patients have to wait in the emergency department for over a day for a bed in a ward. Not just Malaysia, other countries as well, government hospitals. Sometimes patients have to be discharged early, which may or may not be a bad thing because the longer you stay in hospital, the longer you are at risk of developing a hospital-acquired infection or maybe having a medication error or a medical error occur. Overcrowding stresses the healthcare providers and adds to the discomfort of the patients and could lead to non-compliance, or what I referred to before as a theory, practice, ethics gap, which could lead to something happening to the patient. Shortage of government specialists. This is a lack of specialists and it has severe consequences. Delays in specialist assessment, delays in diagnosis and often misdiagnosis, inadequate supervision of junior doctors, treatment errors, and loss of faith, unfortunately, in government hospitals. From my perspective, I like government hospitals. Yes, you have to wait, but in government hospitals, why? Because most of the time, certainly in Western hospitals, that's where most people go. And because most people go there, the doctors get a lot of experience in diagnosing conditions. And if they get a lot of experience, they know what's actually happening. In a private hospital, maybe not. Maybe not. Long patient waiting times. Waiting times to get certain investigations. For example, MRI scans, CT scans, treadmill stress tests for cardiology problems, echocardiograms, even ECGs, angiograms. Can be months, which puts the patient at risk for suffering further deterioration of their condition before they're fully investigated. As I indicated, in the States, even in the UK, patients have been found dead, waiting for certain procedures that they want to be seen by physicians. The two-tier health system. Those who can afford it just go to the private hospitals and they're assessed straight away and treated typically promptly. Those who can't afford the charges in the private sector go to government hospitals where there are delays in being seen, being acknowledged, then investigation, diagnosis and treatment, and this can lead to poorer outcomes. There are those that have and there are those that have nots. This is in the two-tier health system. Government versus private. Rising costs of co-payments. Newer devices and treatment modalities are not provided free by government hospitals. They have to be bought by patients. Things like cataract lenses, plates and screws for fractures, coronary artery stents and interventions, esophageal stents and surgical staplers for colon anastomoses, they have to be bought by the patient before they can be initiated. Some of these devices, as I indicated with certain medications, can be really expensive. This one here, what does it say? 7,000 Malaysian ringgit for a drug-eluting stent. And basically what this means is it's a little piece of equipment that is about the size of a noodle. And it's implanted into an artery, which is typically the heart. And over a period of time, it releases certain medications that now prevent the stent from blocking. Because again, the stent is an artificial device here and it promotes clot formation. So it prevents clots. Yes, the patient will still have to be on things like anticoagulants like warfarin, possibly here now aspirin, etc. But these things are expensive and you have to pay for them. If you can't pay for them, you don't get them. Catastrophic expenditure, as I said. Yeah, look at the cartoon. Intensive care is expensive care. I mean, as I indicated, I've looked after patients in certain countries where they're admitted to intensive care and intensive care costs are incredible. You've got to pay for the intensivist, the intensive care nurse, the ventilator, the monitor, the ECG electrodes, the gauze, the medications. It's phenomenally expensive. And the families of patients with critical illnesses such as heart attacks or strokes or cancer, they're often under severe financial stress. And as I indicated, they can lose their homes. And what are they trying to do? They're just trying to make sure to get the best treatment for their family members. So in conclusion, think of yourself as a patient. And in that way, you'll think of yourself as a patient advocate. And in that way, you'll be the type of nurse, not just to work with, but you'll be the type of nurse that the patient wants to be cared for by. Or you'll be the type of nurse that you want to be cared for by when you're a patient. So you want to be the type of nurse, as it says, when you're a patient, they care for you. Genuinely care for you, not just because they're being paid. Thanks everybody. That's the end of this session. If you've enjoyed it, please recommend it to your colleagues, your friends, and check out some of the other Dr. Manny Learnshops on YouTube. Bye for now.